Dr. Ebueso is a professor of geriatrics and palliative medicine at the Brookdale Department of Geriatrics and Palliative Medicine, the Icahn School of Medicine, and the Hertzberg Palliative Care Institute. He is also the director of the Palliative Care Unit of Mount Sinai Hospital. He is a graduate of the University of Ilorin Medical School in Nigeria and obtained his internal medicine training at the University of Connecticut School of Medicine. He subsequently did his geriatric and palliative medicine fellowship training at the Mount Sinai School of Medicine in New York. He served as the medical director of Hebrew Healthcare Hospice, the director of outpatient geriatric services, and staff physician at Hebrew Healthcare in West Hartford until he rejoined Mount Sinai in 2013 as faculty. His present inpatient clinical practice extends through internal medicine, geriatrics, and palliative medicine, including hospice care. He's also involved with inpatient hospital administration, ambulatory care of older adults, and those with serious illness, and leadership training for fellows and other learners. Thanks so much, Dr. Ebueso.
Yeah, thank you, Lai. Hi, everyone. Good to be here. And we will be discussing end-of-life symptoms. So it's going to be a general approach to how we manage the end-of-life situations in families and patients, focusing on some symptoms, not to the deepest extent of each one, but as it relates specifically to end-of-life care. So I have no disclosures. I have a few slides. So some of them I'll just highlight and some I'll spend some time with. The objectives here will be to just describe the pattern of symptoms in the last hours of days of life, and then talk about the evidence-based approach to the management of some of these symptoms. The list is not, of course, exhaustive. Not included here will be things like fever, spiritual or psychosocial suffering. But these are the common things that you may come across in your practice. There's a concept of symptom cluster, of course, at the end of life. And then there's also what is comfort care. I'm sure everybody would have had situations in which families want to focus on comfort-focused care. And that differs in interpretation. So, but when we say comfort-focused care, we're really referring to the most basic palliative care interventions that will provide immediate relief of symptoms in patients who are very close to death. There's an ever-increasing need for familiarity with basic comfort measure management skills for clinicians, and I believe this plenary is going to be helpful to everyone. So there's a bunch of studies out there that tries to give us the prevalence of these symptoms at the end of life. Some of them are specifically focused on cancer management, but this is roughly what you find out there. Pain may be slightly higher depending on the population you're thinking about. And of course, delirium is not here, but maybe about 50% of end-of-life situations will have delirium or confusion associated with it. So we always think about two pathways when people are at the terminal stages of every disease. There could be the usual road, in which is really not very symptomatic. And we often hope for that, in which there's a road for lethargy, sleepiness, turned patients, semi-comatose to comatose, that leads to death. And then there is the very difficult road that may be very symptomatic, that is heavy symptom burden with neuropsychiatric symptoms. So different sites of care for end-of-life care, as we know, more and more people are at times wishing that the end of life is performed at home under hospice. But again, there's a whole lot of hospital situations in which there's a need for management of end-of-life care, including the ICUs and separated units like the palliative care unit. Most places, however, have hospice cadre beds in which they collaborate with hospice agencies. There are standalone hospice facilities, particularly here in New York, where we have some place like Calvary and some other hospice facilities. Some assisted living facilities, of course, collaborate with hospice agencies or palliative care programs. So how do I know when a patient is actively dying? There are commonly about 5 signs that you see 3 days before the end. Trady, loss of trachea pulse, mandibular movements, decrease in urinary flow, anuria. Different respiration patterns, actually, there may be Cheyne-Stokes breathing, or actually very fast breathing compensatory for metabolic acidosis that you see at the end of this. And then there's, of course, increased oropharyngeal secretions. Some of the neuromuscular signs will include non-reactive pupils and decreased responses to stimuli, inability to close the eyelid, and drooping of nasolabial flows. There could be neck hyperextension also noted. So, how do you approach the symptom management on a general basis before we go into individual symptoms? Differential diagnosis in terms of etiological causes is important. Disease burden is important. Assessment can vary, but totally key to symptom management. So it has to be an accurate, unbiased assessment process. And at times, families and even caregivers can have barriers to assessment. It's after the assessments that you consider the best treatment options, considering the goals of care, making your recommendations strictly based on goals and values, and then you implement the plan. It's important to reassess at regular intervals and continue education for both the patient and the team. So let's start with pain. Again, we will not do a deep dive into pain management. We'll just skim through a couple of slides and talk about the relevance or what we do at the end of life. So the first thing is really want to figure out what is the source of this pain, and it's of course going to guide your choice of therapy and how you approach it. So multiple possibilities for the causes of pain at the end of life. Again, the basic nociceptive neuropathic classification or definition of the pain is totally important in managing and choosing your medications that you're going to use. Managing the core medication that is used here is, of course, opiates. And at the end of life, there's a place to start on an intermittent basis, on a PRN basis, depending on the assessment and the disease burden. For constant pain, though, you may want to schedule some doses, adjusting for renal impairment, liver impairment, older adults. Neuropathic adjuvants, this is, again, after doing the assessment, there are a bunch of them, and we're going to see that on the next slide. 50% of patients will probably respond to a single agent for neuropathic pain, but from my experience, you tend to need to combine a couple of agents for neuropathic pain. There are other adjuvants that could be added, and again, if you're thinking about receptors that could cause pain or the pain location, you may be able to add antispasmodics or acetaminophen. It's important to always think of total pain at the end of life, including existential pain. So starting doses here for what we recommend, both for morphine and hydromorphone, the two most commonly used, probably more hydromorphone in liver and renal disease. Breakthrough pain, some literature go from 5 to 20% of 24-hour dose. Frequencies usually based on whether it's IV or PO, thinking about the peak effect. And you want to think about whether you want to have holding parameters or not, depending on how far advanced or how close to in terms of short prognosis. For neuropathic pain management, the adjuvants, they are first and second line therapy. And again, like I said, less than 50% will respond to a single agent. So combination therapy at times will work better. I've always found out that the addition of opiates, to some extent, depending on the cause and disease burden, particularly at the end of life, is very helpful. What are the side effects that we worry about with opioid management? The things that most families will want to talk about and negotiate around is sedation. It may or may not be important. it varies widely on the goals. Constipation is not a high priority in patients with prognosis that are pretty short, unless it's symptomatic. The more concerning are the neuro side effects like myoclonus or even frank seizures, and in such cases, you either manage or dose reduce for those complications. Most other complications are more applicable upstream, and people develop tolerance within days to that or to those ones. The next symptom moving things along will be dyspnea. It's a pretty common symptom at the end of life. There's this robust definition by American Thoracic Society, but just what I want to highlight that dyspnea is a subjective experience. I sometimes have to rely on other things like tachypnea or distress as a marker when the patient cannot communicate. Robust pathophysiology is included in the slides. There are about 4 or 5 different things that may cause dyspnea in every patient. And in terms of etiology, but toxic metabolic causes should also be considered, particularly in acidosis and uremia at the end of life. So in management of dyspnea at the end of life, self-report is the most reliable measure. Dyspnea can be very distressing to caregivers. The respiratory rate, O2 sat, do not really correlate with the objective assessment of breathlessness. In thinking about the management, we want to treat reversible underlying causes. That's where things like Lasix will come in when we're thinking about congestive heart failure, for example, and then pharmacologic and non-pharmacologic thought processes. In pharmacologic management, the gold standard is still opiates, starting at low doses. It does reduce the sensation of shortness of breath. Both oral and parenteral are very effective. You may come across this in your board exams. Nebulized opiates is not effective as more than placebo. And at the end of life, particularly, there are no ethical or professional barriers if the intent is just to relieve suffering. Again, you can start on a PRN basis and titrate as needed or consider scheduled doses as needed. People always ask about anxiolytics. It's not the first line of management. There are adjuvants, particularly when there's association of anxiety. But at the very end of life, when sedation is no longer a concern, it can be very helpful. The non-pharmacologic things we can think about would, of course, include repositioning, head of bed elevation, a bedside fan, and consider other factors that you could do. There's always the question of do glucocorticoids have a role to play in the end of life? Unless treating something very specific like COPD exacerbation or SVC syndrome, or in cases of obstructions, there's a mixed evidence to its usability. Again, supplemental oxygen is very symbolic. It's more of symbolism for families. If the patient is hypoxic, yes, there may be a trial of supplemental oxygen. That's reasonable, but if not hypoxic, bedside fan with that here stimulating some receptors on the face is quite helpful. So it's important to just educate the family and let them understand their respiration will change with accumulation of metabolic acidosis, and to explain that irregular respirations are expected at the end of life. So we go to the next one, which is delirium, pretty common at the end of life. The definition is here highlighted. It's disturbance of attention and awareness. At the upstream levels, there might be cognitive affecting the cognitive status of the patient. At the end of life, delirium can be hyperactive or actually a mixed picture. Again, listed down in the boxes as multiple possible causes, but they all have almost like a common end of toxic metabolic encephalopathy, depending on how far advanced the disease situation is. Families are always worried about agitated delirium, particularly at the stage of disrobing, and the lack of dignity that is associated with that. And that is one reason why the use of medications at the end of life for delirium is probably kind of advised earlier than later. Low threshold to start that. So the non-pharmacologic management, again, more applicable upstream, will be to encourage the family to be around, familiar presence, things like orientation, limiting nighttime interruptions may be very helpful at the early stages. At the later stages, again, it's a management with very low threshold to start managing with medications. So there are different classifications of medications that can be helpful. The skill here is to be able to see whether your choice will also be helpful in managing other symptoms that might be associated with the end of life. So the first generation antipsychotics are pretty helpful. They're more, they're less sedating, they're more effective. Olanzapine is beginning to really play major roles in many things now at the end of life, other than just delirium, like in nausea, anxiety. It's more sedating, so that may be helpful too, something to consider. And the others, lorazepam, there are many studies that talk about when you combine lorazepam with antipsychotics, you may have better responses. Again, we are thinking end of life, where sedation is really not an issue, but there may be better control of hyperactive agitation in hyperactive delirium in those cases. Other agents to consider, Presidex is almost like an anxiolytic. It's sedating. It's a little bit more expensive, available only in the hospital setting. But again, it's moving into the literature of the management of delirium in end of life. The other four things that I've listed here is just for you to kind of look up, not very high quality evidence in their use in the end of life. Constipation is pretty common at the end of life. Very robust, again, definition of what constipation is. And I just put in this slide so that we can see that there are different classifications to it, both the secondary and the primary constipation, and then IBS with constipation. We think of the multiple possibilities, multiple causes of constipation, but at the end of life, we really want to focus on a few things: decreased PO intake, decreased mobility, a lot of medication side effects, obstruction, and then metabolic changes. So the big question is, should you really worry about bowel movements at the end of life, or when should we worry about bowel movements at the end of life? And I think the goal is to focus on whether the patient is uncomfortable or in some form of distress. And we know it can also cause delirium. However, parenteral regimen is very helpful at the end of life for as long as it will not cause more discomfort with moving the patients back and forth for cleaning and bed care. So there are different categories, and I put these slides there so that we can look at when do we use what. You have to have a lot of fluid intake to be able to use the bulk laxatives, and that may not be workable in debilitated elderly patients. Osmotic laxatives, we want to avoid magnesium in those with renal insufficiency. It may be associated with electrolyte abnormalities, as these are hyperosmolar agents. Stimulant laxatives, very important to add in, for example, in opiate-induced constipation. It's rather rapid in acting, causes bowel movement in hours, but can also cause abdominal cramping. And I will not think about using them in intestinal obstructive cases. Colace and co have not been shown to be more effective than placebo, particularly in opioid-induced constipation. Prokinetic agents are useful more upstream, but we want to be careful about tardive dyskinesia, particularly with metoclopramide. And of course, like I said, either at home, hospice, or in a lot of sites, enemas and suppositories and disimpactions helpful for as long as it will not cause more discomfort in the patient. People always ask about when do you use the opioid receptor antagonists, naltrexone and naloxone. I have my own inclusion of things and exclusion criteria. If the patient has been on the opioid for more than 2 or more weeks, and I've received stable doses of laxatives for more than 3 or more days without relief of opioid-induced constipation. Having said that, I want to be careful about constipation that is not caused primarily by opiates, mechanical gastrointestinal obstructions, indwelling peritoneal catheters, clinically active diverticular disease, fecal impaction, all of those things that you really want to rule out with a CAT scan before you place the patient on this. So we go to nausea and vomiting, and you really want to, there are 2 different things that at times present together, and you want to think about location, sites, etiology, receptors when you're thinking about nausea and vomiting. I put these slides there to kind of break down the multiple possibilities of generating nausea and vomiting, and the vomiting centers with some of the receptors. The next slide is a little bit more just to present it to relation to the brain in itself. But the key site will, of course, be the chemoreceptor center at the base of the fourth ventricle. That's where a lot of the metabolic encephalopathy or metabolic causes will affect. Then, as far as the gastrointestinal tract, when you have mechanoreceptors and chemoreceptors centers also. Etiological classification of the possible causes of nausea is presented in this chart. We want to common causes in end of life. Of course, they are multifactorial, and at times they are often certain causes. So it's always medications, reactions to medications like opiates. And then we want to think about uremia, bowel obstruction, gastroparesis, ascites, increased intracranial pressure, and again, toxic metabolic causes. What is the general approach? Reassuring the patient and provide information both to the patient and the family. Little things that can be done include improving the environment, calm, avoiding odors, avoiding rapid movements, good mouth care. We hydrate as appropriate for as long as the heart can take that, and then limit eating to small feeds. So 3 things to think about: reducing and removing offending agents if possible, drug selection based on the pathophysiology of the underlying cause, and then considering combination therapy. Antiemetics, antacids, multiple things can be used to control nausea and vomiting. Broadly, they're classified into 2 groups: those that have the highest therapeutic index for antiemetic agents and those with the lower therapeutic index. But again, the chart here is really more to focus on what do I think about in my drug choice. So for dopaminergic antagonists, for example, is most frontline, particularly for chemoreceptor trigger zone. Serotonin antagonists, Zofrans and co, I need to worry about QTC prolongation, may cause constipation or headaches. Both the oral and IV equivalent dose, when dosed properly, are effective. Antihistamines, most helpful in cough-induced vomiting. They work more on the vestibular afferent, and anticholinergics can be helpful in bowel obstruction. They may have acetylcholine receptor blockage side effects, but helpful in bowel obstruction. Prokinetics, when we think that peristalsis is suspected in the etiologic cause of the nausea and vomiting. Steroids, maybe in CNS diseases, underestimated, not understood, cost-effective in chemotherapy-induced nausea and vomiting. Octreotide, we usually use, of course, in bowel obstruction. Parenteral, available in a number of ways, but it's pretty expensive. There is an increase now request by patients for cannabinoids, particularly marijuana, to help with nausea and vomiting. And in other hospitals now, kind of generating workflows to make that happen. So we move on to increased oropharyngeal secretions. There's always a debate about should this be medicated or not at the end of life. A lot of secretions can be produced, however, in a day, and they do accumulate to cause the noises, the gurgling, the rattling, called the death rattle that we hear about. It disrupts sleep. It may worsen dyspnea. People can aspirate, and just a lot of complications from that. But most importantly, it may be distressing to the families as they come to visit or stay overnight. There are majorly two types of secretions. The type 1, which is mostly salivary, and those can sometimes be cleared or dried out. Is the type 2, the bronchial secretions that are harder to clear. Of course, it's a good predictor of death in hours to short days. So non-pharmacologic management will center around just counseling the loved ones on what to expect. In areas where the goals of care is aligned with discontinuation of IV fluids and nutrition, that is very helpful. And minimizing the medication fluid burden. Positioning, like I said, may be helpful. Some have gone as far as to try the Trendelenburgs for a few minutes and then try to suction. But deep suctioning can be very traumatic and can generate bleeding. So we want to avoid that. Pharmacologic management, these are the three commonly used agents. Most people, particularly in hospital, they use the glycopyrrolate. It does not cross the blood-brain barrier, less telerogenic, and 5 times as potent as atropine in code. But atropine is cheap. They're just drops and can be applied in multiple locations, including the home. Scopolamine is more reserved for when you have other vestibular symptoms, and there may be side effects. The first line is to counsel the families about secretions. So neuroexcitation, I think we're doing well with time here. Neuroexcitation, always a complication of metabolic, accumulation of metabolic agents. Could come in the mild form of myoclonus, which is the brief, sudden, involuntary twitchings. I've seen it escalate to frank seizures, particularly those that have neurological injuries, and at times are side effects of medications. So opiates, one has to be careful about the use of opiate, particularly as the renal function declines with time, particularly with morphine. Infections can also cause neuroexcitation and electrolyte abnormalities. The approach to this is to first discontinue non-essential medications, consider dose reductions, opioid rotations. The natural opiates are more the more cost-based than the synthetic. Again, thinking about using benzodiazepines to start off for your management of twitches before it goes into frank seizures. And we've had to use Keppra at times. I have a bigger chart that shows the ones that could be used per rectum. Diazepam, lorazepam, for example, at home can be used per rectum for hospice patients. Midazolam is fastest in action. mostly IV or buccal. There's intranasal preparations of that. And in rare instances, particularly to control seizures, you may have to go as far as to use phenobarbital or propofol, but of course that will be in hospital settings. Anorexia cachexia is more upstream. It's really not, of course, families will always ask questions around why are we not feeding, why are you not giving some form of nutrition. There's significant weight loss. So the idea of including this is to always think about the two most common causes of cachexia, primary cachexia and secondary cachexia. The primary one is the one that is associated with the complex metabolic syndrome and is partially explained by only decreased nutritional intake. That is the education that at times we give to families that unfortunately at this point, there's very little that can be done. Secondary cachexia is when, okay, maybe it's secondary to inadequate caloric intakes and modifications can be done to the diet to see whether it helps. So non-pharmacologic management is to really encourage oral feeding as best as possible and only when the patient is interested. Determining whether the assistance is needed, liberalizing the diet, encouraging eating favorite foods and tastes over calories, and of course, smaller frequent meals is better with increased calorie density. It's once there is that dynamic of the family wondering about and asking about nutrition, involving them in that role is therapeutic for them, particularly in cases where they have nothing else to offer their loved ones. A lot of things are in literature that could help more upstream again, but they do come with things to think about. Progestagens like megestrol can, of course, has its own complications, and it's only been found to be helpful in about 15 to 20% of patients that gain weight. Steroids may improve appetite and quality of life, but not necessarily body mass. The effect is usually temporary and may be reserved for patients with poor prognosis. Again, medical marijuana cannabinoids may improve appetite and mood, but not necessarily improve weight gain. Yeah. Higher doses of mirtazapine may help stimulate appetite. Again, this is more, again, further upstream. And like I said before, olanzapine is now, again, being thought of as something that may improve appetite, particularly in people undergoing chemotherapy. When do you think about artificial hydration? In patients that the goals are, should I say, they're still awake and alert, have some measure of prognosis, and you want to reverse renal isothemia, there's a mixed evidence that it might prolong dying process. So, and also maintain the appearance of doing something. But the negative side effects is that there may be dehydration, AKI. IV will limit mobility, causes edema, causes pulmonary edema, increase oropharyngeal secretion. So we have to think about all of these things and be able to counsel patients accordingly. Dry mouth associated with end of life. The approach is to moisturize oral swabs, water sprays, avoid irritants, and you can do give some things for saliva stimulation. Reviewing the medication, giving salivary substitute, and reviewing like stimulants, using stimulants like cholinergic agonists in extremes of cases. And I think that's my last slide. So now I have this question, which is just a case and one, and I'm not sure if anybody wants to get a stab at it. So you are called to see an oncologist service this metastatic prostate cancer with disease progression, multiple lines of therapy. You determine that patient is no longer appropriate for cancer-directed therapy after your brilliant family meeting and sharing the news and prognosis of short months. And that prognosis may be shorter. He decides to make himself GNI, DNR. He says it's too hard to think about intervention given the bad news he received during the family meeting. He indicates that he hopes that he could see his daughter just to say goodbye. And daughter is coming from Michigan. I don't know why they chose Michigan, but it's coming from Michigan in 2 days. So this morning, the intern is saying now that the patient is more confused, trying to get out of bed, checking vital signs. They are stable. Decided to obtain labs that are not really remarkable, but maybe on the drier side. And calls you to ask for a visit and possible PCU transfer. Seeing his chart, seeing the bowel movement is 2 days ago. One PRN of Aldo was given that morning. The nurse says Aldo did not really do much, and otherwise his exam is otherwise unremarkable. So what would you recommend as a next step for this patient? And we have a couple of choices. We could start an IV adenomorphone. Seems really confused now. So 0.2 milligrams QPRN. You could call the daughter and share the news and tell her not to come as the patient is now having a shorter prognosis. You could add Ativan to ensure that he's comfortable for the time that he has left. You could actually consider a trial of IV fluids, or you could just put in a bilateral wrist restraint. And I'm not sure how I would know how people will pick their answer. But I think the answer here is probably considering a trial of IV fluids. There's a justification because he did specify that his goal is to see whether his daughter can make it. And there's nothing here that says that something really changed much. And dehydration with hypercalcemia may be contributing to the agitation. So I think he may benefit from some hydration, and at least as a start to see. So thank you very much. I believe that's the end of the take-home points here is constipation prevention is key, nausea and vomiting, choice of antiemetics based on pathophysiology, anorexia, cachexia, funal, reversible, just a sign of disease progression, and dyspnea self-report as the only reliable measure. A long list of references. Thank you.
Thank you so much, Dr. Apoisel. We just have a few questions in the chat. We'll just start with at the top. Do you start weaning down medications like SSRIs or gabapentin that may have withdrawal symptoms if they're stopped abruptly in anticipation that a patient may stop taking PO meds?
Great. So I think the first thing I want to know, the first thing that, of course, helps to determine that is prognosis. Do you think it's something that's on the shorter end, or do you think that this is something that may be more along the line of weeks to months? So if I'm thinking hours to weeks, hours to days on the shorter end, it's better to start dropping it early. But again, remember that most of the withdrawal symptoms can be managed with other things. Burden of medications is more important at this stage than trying to prevent side effects. But if you're thinking about the mid-range where you have days to weeks, you can start tapering down and watching how the patient responds or reacts to that. But on the longer end, you can continue because there is still the mood that it's important that we manage depression and anxiety, bipolar disease, manage all that so that there's a quality of life issue attached to that.
Thank you. We also have, when would you choose a benzodiazepine instead of haloperidol for terminal delirium?
Again, excellent question. So remember that Haldol, for example, is less sedating. So if there are family interactions that the patient value along with their goals of care, I tend to lean more towards at least a trial of antipsychotics. But when things are now further downstream and the patients and families really are more worried about agitation than sedation, that is when I start to add on initially the anxiolytics maybe on a PRN basis for extremes of agitation as the Aldol kicks in. But towards the end, as patients nevertheless unresponsive for many other causes going on, that is when I tend to do more palliative sedation that is lean more towards anxiolytics.
Thank you. The last question that we have for you is if you can talk about balancing wakefulness. This is kind of similar, balancing wakefulness and symptom management for families who are worried that opioids may cause oversedation or speed up death. I guess how to manage that and how to talk about it, maybe.
That is such a common, I'm sorry, that is such a common issue in the palliative care unit. It's in getting the families to buy into the process, exploring why they want the patient to be awake in spite of symptom burden. Because if the symptom burden is very high, at times I sit with them in the room for them to see our own point of view. That at this point, another way of showing love is to make sure that the patient is not uncomfortable. And as much as they want the patient to be awake, if they witness like rapid breathing that is very laborious to watch, or 10 out of 10 pain that is causing a whole lot of other problems, we negotiate around, why don't we try and see? And I really always emphasize that some of these side effects, you do develop tolerance over time. So why don't we give you that trial run and see? Particularly for those that have more like days to weeks, that you think that by the time you control the symptom, the patient will have time to overcome the tolerance. So it's in back and forth, not being in a place of judging the family, just a place of trying to understand where they're coming from and getting them involved in the process. Most often that times it works. It works for as long as they see you as participating and not just doing. I think they respond good.
A common but challenging situation, maybe.
Yeah, very common, very common.
Well, thank you so much for your time. We really appreciate you giving your presentation.
Thank you so very much, everyone. Thank you. Bye.
And for all of our participants, that is the end of day one. I know it's a long day, so thank you for all your participation. We really appreciate it. I hope it's been helpful so far. We've got 3 more days coming. Just like today, tomorrow we'll start at 8:55 with just kind of a brief introduction from our course directors. And then at 9 a.m., we'll have our first presenter, Dr. Sarah Rostansky, come on and start talking about strokes. Thank you so much.